Switching gears a little bit to ROS1, when a gene rearrangement occurs in ROS1, it can drive tumor cell proliferation, survival, and metastasis. ROS1 rearrangement is known to occur in about 1% of non-small cell lung cancer patients. Importantly, at the time of diagnosis, 20 to 30% of these patients present with accompanying brain metastasis. Of the 1.5 million new cases of non-small cell lung cancer worldwide each year, approximately 15,000 may be driven by the oncogenic ROS1 fusion. What is available for ROS1? Well, the two approved ROS1 tyrosine kinase inhibitors are crizotinib and entrectinib. There are a few off-label agents that are available, and there are 3 second-generation ROS1 TKIs in development, which we will talk about in the following slides. So first thing to note, ROS1 structure is very similar to ALK. Indeed, ALK and ROS1 share 77% of amino acid identity within the ATP binding sites. Due to this high degree of homology between the ALK and ROS1 tyrosine kinase domain, the ROS1 tyrosine kinase have been known to be highly sensitive to crizotinib in preclinical models and from case reports. The FDA approval of crizotinib in patients with ROS1 non-small cell lung cancer was based on the expansion cohort of 50 patients utilizing crizotinib with ROS1. As you can see here, the objective response rate was 72%. Median duration of response was 17.6 months. Median progression-free survival was 19.2 months. Common adverse events included things like visual impairment, diarrhea, nausea, edema, constipation, and vomiting. Entrectinib is also FDA approved. Entrectinib demonstrated an objective response rate of 77%, duration of response of 24.6 months, and median progression-free survival of 19 months in the overall population. And in the patient population of baseline brain metastasis, the response rate was 74%, the duration of response was 12.6 months, and median progression-free survival was 13.6 months. For the most part, entrectinib was well tolerated, as most of the treatment-related adverse events were low grade. But because entrectinib is also a potent TRK inhibitor, the occurrence of adverse events potentially related to TRK inhibition, such as dizziness, weight gain, paresthesias, and cognitive changes, was not unexpected. There is some data on ceritinib and ROS1, but from a limited number of patients. For crizotinib-naive patients, the response rate was 67%, duration of response was 21 months, and median progression-free survival was 19.3 months. There is also data to support the use of lorlatinib in ROS1. The lorlatinib study enrolled more ROS1 patients compared to the ceritinib study, totaling at 69, and 21 were tyrosine kinase inhibitor naive, and 40 had crizotinib as their only prior tyrosine kinase inhibitor. The response rate was 62%, and median progression-free survival was 21 months in the tyrosine kinase inhibitor naive group, and in the prior crizotinib-only group, the response rate was at 35%, median progression-free survival was 8.5 months, and median duration of response was 13.8 months. The intracranial objective response rate was at 50%. Here is a quick summary slide of the approved and unapproved ROS1 tyrosine kinase inhibitors. Now moving on, here is a slide on the mechanism of resistance to crizotinib or entrectinib in ROS1 non-small cell lung cancer patients, and the slide credit goes to Dr. Jessica Lin. As you can see from the pie chart, G2032R was seen in 33% of those with resistance to crizotinib. And the current available ROS1 inhibitors are not potent against ROS1 G2032R. And as shown in the IC50 table, this is where the next generation drugs like repotrectinib and taletrectinib come in. Repotrectinib is a next-generation ROS1 TRK inhibitor designed to overcome tyrosine kinase resistance, especially solvent-front G2032R, which first-generation tyrosine kinase inhibitors cannot overcome. Repotrectinib is highly potent and structurally differentiated with a small or low molecular weight and rigid 3D macrocycle, and it is designed to bind completely inside the ATP pocket, even in the presence of resistant mutations. It has the potential to address resistance from prior lines of tyrosine kinase inhibitor therapy, but it may also prevent or delay the emergence of these resistant mutations. As shown here, the objective response rate after one prior ROS1 tyrosine kinase inhibitor and no prior chemotherapy was 37.5%, with the clinical benefit rate being 82.1%. Dizziness and dysgeusia were common. Here is data on G2032R and brain efficacy. In those patients with G2032R resistance mutations, the objective response rate was 58.8%, with 70% of patients exceeding 6 months of duration of response. The intracranial efficacy was also promising too, with intracranial objective response rate at 87.5% in ROS1 tyrosine kinase inhibitor naive and 41.5% in one prior ROS1 tyrosine kinase inhibitor and no chemo. Taletrectinib is another second-generation ROS1 tyrosine kinase inhibitor. Here's data from the Chinese phase 2 study, or the TRUST study, which showed an objective response rate of 50% in crizotinib pre-treated patients. The intracranial objective response was excellent at 91.7%. There is also an ongoing study called TRUST-2, which is the global version phase 2 study of taletrectinib. The last agent that I wanted to introduce today was MVL-520 or Nuvalent 520. This is a very important new ROS1 inhibitor that is coming out. It is considered brain penetrant and a TRK-B sparing small molecule inhibitor of ROS1 with activity against the frequent drug-resistant mutation of G2032R, as well as others, including D2033N. The initial preliminary efficacy results were presented last year and showed an objective response rate of 48% in all evaluable patients, 78% in those with G2032R, and 73% in those with history of brain metastasis, and 53% in those who had 2 or more ROS1 tyrosine kinase inhibitor and 1 or more chemotherapy treatment, and 50% in those with prior lorlatinib or repotrectinib treatments. But we must be careful as the numbers that have been reported here are relatively small. Again, although the numbers are still limited, MVL-520 appeared to also have promising CNS data and safety data in the patients with measurable CNS metastasis. There was 3 out of 3 patients with intracranial response, and the objective response rate was 73% in response evaluable patients with history of brain metastasis. Importantly, no brain progression was observed in any of the 35 treated patients. Safety was also looking promising too, with no DLTs or dose-limiting toxicities, no treatment-related serious adverse events, no adverse events leading to dose reduction or discontinuation, and no treatment-related dizziness. All right, here is the list summarizing the three second-generation ROS1 tyrosine kinase inhibitors in development. They all appear promising with brain activity as well as activity against the resistant G2032R, and we will await for these studies to mature